TopMedTalk.
Hello, I'm Desiree Chappell, and this is TopMedTalk. I'm here with Monty, Mythen, editor-in-chief. Well, TopMedTalk is in Orlando, Florida this week, and we're here for the SPACI 14th Annual Perioperative Medicine Summit. Now, SPACI is the Society of Perioperative Assessment and Quality Improvement, and the Perioperative Medicine Summit is the Society's annual international multidisciplinary meeting, and it's typically held in late Florida, early March each year. Now, Monty, you know a little bit about this organization, don't you?
I do. I was privileged to be a founding board member back in 2006, I think, now coming up, which was a great privilege to be part of that. Angela Bader and colleagues, who we'll talk more about later, and other members of that founding board, I think, were people like Ross Kerridge and Lee Fleischer.
Oh, I love it.
So there we were back in the day trying to do our little bit to help the international perioperative medicine movement.
Yeah.
And it's a great, I've been a number of times. It is a great meeting.
It is. It is very evidence-based and very evidence-heavy, and which is good because you have to have that piece.
Yeah.
I mean, you have.
It's also very, very practical.
It is very practical.
So I think the thing that distinguishes it from more of the anesthesia-bent meetings, although everyone says multidisciplinary, the ones that are more enhanced recovery are wrapped around the immediate surgery bit. This is tilted in some ways more towards the fuller preoperative component of it. So I think there are a lot more internal medicine doctors, a lot more other providers who are involved in the preoperative assessment, evaluation, and optimization of patients.
Yeah.
They still do all the same type of stuff, but I think that's the tilt that makes it different. Like that session we had this morning, it was a great session. Yeah. But it's very much that fine print of tweaking the meds preoperatively.
Yeah. All right, let's talk about the sessions in just a second. But so we're here. We're excited to sit down with some of the key opinion leaders and our colleagues to talk about kind of our shared purpose, disseminating high-quality healthcare education to the broad audience of care providers. Now, throughout the next several days, we're going to have lots of discussions with everybody that's here, talking about a lot of what we've heard this morning, the most recent literature in this area and translating it into everyday practice. I'm excited to sit down with some of the leaders now here in the organization and see where the organization has been, where that is, but where it's going, and how they're addressing key concerns in the field of perioperative medicine, because I think that's really important. So getting kind of diving into what you heard this morning, I think we started out with kind of it was a pretty heavy punch of...
It was hard. It was fantastic.
It really was.
But it was hard to keep up.
Yeah,
luckily, the summary, the take-home messages were summarized beautifully, so
Wonderful.
we could get the big picture, the big picture thing.
Yeah, so we started out, Stephen Cohn, who is a past president of the organization, started the morning off.
The session was divided in sort of cardiac, diabetes, pain, pulmonary, roughly, which we can loop back on. But Steve did the cardiac, the big trials of the last year, basically.
Yeah. What did you kind of take away from that?
Well, big takeaway messages, the two that I chose, was there's a publication by Holman et al. In Anesthesia and Analgesia, published in September 2018, which is the old classic about what happens if you do or don't stop ACE and ARBs on the day of surgery. Now, lots of opinions about when you stop them, and actually what wasn't covered, more opinions about if you do stop them, when you should start them again. So the takeaway from that, it was a meta-analysis, but the takeaway from that was if you keep the ACE and ARBs going, there is more hypotension. But there was no clear associated effect on MACE and mortality.
Yeah. What's
so it's
MACE again?
It's the major adverse cardiac events. Right. So I think we can take from that is it made the trial, it's observational. It may not be big enough to be able to say that although hypotension happened more often, the hypotension wasn't associated with harm, but also stopping the ACE and the ARBs was not associated with any adverse outcome. So on balance, as we've done often on TopMedTalk, hypotension appears to be associated with harm. It's probably best to continue to stop the ACE and ARBs, because no badness happened in the patients who stopped the ACE and ARBs. And then the final plea from Dr. Cohn was to say we need a large prospective randomized control trial, which I believe is ongoing. Yeah. So I believe Gareth Ackland and maybe other people is leading a large trial to determine prospectively stopping or not stopping the ACE and the ARBs.
Interesting. And then the follow-up to starting, when to start them back? Is that
Absolutely. Closing the loop on that one. Because I think the general wisdom at the moment is the people who are quite rightly worried about the hypotension is unless the patient is, stellar, walking around, clearly doesn't have orthostatic hypotension, clearly has no pressure issues, they're out of the woods, ideal enhanced recovery patient, then sure, you need to restart the ACE and ARBs at some stage.
Yeah.
They're not an acute medicine, they're a over time medicine. But what you don't want to do is really start them in the person before you've tried to stand them up if they're at risk of orthostatic hypotension. Kind of like, why don't you wait until the pressure sags over and you're out of the woods a little bit further. So I think that's current eminence-based medicine. That's the current tip of opinion.
And then, let me guess, MINS.
Yeah, the MINS. So,
Here we go.
Well, it was it was Abbott et al. I think it was another ANA paper, June 2018. I think it's another subset of one of the very, very big studies that we talked about before. I think it's from Vision again. And it's looking at MINS, this myocardial injury, as judged by a troponin rise. And I think the threshold was 0.03 nanograms per mil post-operatively. And these are large cohorts of adult, I think, elective non-cardiac surgical patients. And you could say, shock, horror, probe, or no surprises there. Tachycardia and hypotension did appear to be associated with a worse outcome. So again, there are associations, but quite striking if your heart rate's over 100 or your systolic is less, not a MAP, but a systolic is less than 100 in about 15,000 patients, I think it was, is that you had a statistically significantly increased incidence of the myocardial injury and death. So it looked pretty clear on the data I saw presented, and we can pick this up hopefully with Dr. Cohn later if we get a chance to interview him, is that there was more mortality. So that takeaways from me is continue to not let people get tachycardic and hypotensive and stop the ACE and ARBs.
Yeah, there's a little bit more to add to that story, right? The ongoing story.
Absolutely.
So then Barbara Slosky picked up. So she is the director for this meeting.
Yep.
And so it was great to hear from her. She did a quick overview too. I started getting a little bit left behind on some of it, but I know that you were writing furiously. So she was kind of the hematology, talking about anticoagulants, yeah? Yeah,
and again, a couple of big takeaways from me there. Again, all dominated by large observational studies which inform trial design. But there was the first paper, which was looking at warfarin versus so-called DOACs, which are the oral anticoagulants, the BANs, the rivaroxapan, the bigatran, the pixaban, medications that have crept in to be more mainstream as opposed to warfarin for people with, for example, atrial fibrillation. So we come across those every day of the week. And basically the takeaway from that was that warfarin, in the context of major surgery, for people who are on warfarin as opposed to people on a DOAC, did seem to have more major bleeding. So it looked as though the perioperative bleeding risk was higher. Now, a number of limitations. There were low bleeding risk procedures, we were told, and there were patients predominantly with a normal creatinine. So we can't apply it everywhere. And this was specifically looking at non-valvular atrial fibrillation. So again, I hope we'll get a chance to do a much deeper dive into that. Because I think the trend is that we're going to see most of our patients on DOACs in the future. Yeah. Anyhow, that's the direction of travel. The one that caught my eye, that was interesting, it reassured me, but it was really the next one, which is a large Danish registry study from BUT-DH, from the Journal of the American College of Cardiology. It's a retrospective Danish registry study. They were looking at the risk of thromboembolism with atrial fibrillation following non-cardiac surgery. And they were looking at the initiation rate or not of giving anticoagulants post-operatively. And I think the anticoagulants, they didn't divide up too much, but it seemed pretty clear that patients who did have atrial fibrillation, who did have an anticoagulant initiated, had better outcomes. They had a lower risk of stroke and death. Now, again, these are associations, not prospective randomized controlled trials. They also noted that of the various different anticoagulant, and I encourage everyone to read the articles in detail, and we'll go over them in a granular way, is the initiation rates of anticoagulation were disappointingly low, is one of my takeaways from that, because it still happens relatively infrequently that patients are getting in this large Danish registry study. We're getting the anticoagulant in the context of new
onset
AF, which kind of
surgery,
we're told we're supposed to do, and I think some of us think you're really going to give someone anticoags for that long, but the data's getting clearer on that, I think.
Yeah.
One more takeaway.
Oh,
there was the aspirin.
Yes, that's what I thought you were actually going to say that one.
It was actually the Hood B.R. et al. JAMA Surgery 2018, which was the retrospective review of about 42,000 patients having a primary total knee replacement. And it looked at aspirin, so deliberately giving aspirin as an anticoagulant perioperatively for DVT prophylaxis versus others versus none.
Yeah.
And there seem to be quite big differences in the rate of PE and DVT in the whole thing. And aspirin, basically, it seemed to be was non-inferior.
Hey, we have one of our friends of the family saw Aronson join us, Dr. Aronson.
Dr. Aronson, how are you, buddy? Do you want to get your sound levels right there?
I think I'm good. I'm testing. I think I'm good.
You can bring your microphone in a little tad, I think, there, so we were going through the opening session, and we just got as far as the aspirin data on anticoagulation for total knee arthroplasty, and the fact that it appeared to be non-inferior to other alternatives, which I hadn't really... I hadn't clocked any of the data to suggest that before.
Right. No, I think that was noteworthy. Certainly recalibrate some of our biases and presumptions. And I think it's an important question to ask. As was pointed out in the session, there were some flaws and limitations to the study design, but it certainly raises the question for us to begin to challenge those traditional presumptions and assumptions that we make.
I was saying for the previous bits, the takeaways were on the cardiac front was probably carry on stopping the ACE and ARBs because you get more hypotension.
I think so. I think there was a nice meta-analysis presented as well as some individual single-site studies that kind of drove that nail solidly into that coffin, if you will, on the question as to whether or not ACE inhibitors are contributory to intraoperative hypotension, and I think there's solid evidence now and compelling evidence to say that there are. So the reasons for decreasing or stopping rather them beforehand to mitigate the anticipated intraoperative hypotension is a compelling case. I think if I could speak further to that. Interestingly, though they measured the process outcome of intraoperative hypotension, they didn't see great significance or any significance at all in the outcomes of mortality or MI by the metrics that they use, though I wonder if they used metrics that were sensitive enough to look for that. And I tie that to some of the work of Dan Sessler and the sort of connectivity, and I think there's great discussion now about hypotension, however we define that threshold, and the strong relationship with a marker of intraoperative troponitis or myocardial injury. And that wasn't looked at with the same degree of sensitivity as other studies have, and I think we need to connect those dots, if you will.
Because that was the tension that I wrote down between the two back-to-back studies that referred to is keeping ACE and ARBs going, more hypotension, no worse outcome. But follow-up trial, vision observation, tachycardia, hypotension, worse outcome,
right?
And a strong signal, which
exactly, and other studies that showed very strongly that there's a tight association between the presence of intraoperative hypotension and myocardial injury, and so I think we have to be very careful not to draw the conclusion that although hypotension was very strongly associated with ACE inhibitors being continued, albeit maybe without outcome differences. I think that's something that's worth challenging because it's not jiving with other data.
I was going to jump ahead to the opioids, which is Paul Grant, I think, was up
Paul
next.
Grant. Yeah, he kind of rounded out the
So I think he told us about a meta-analysis about opioid respiratory depression risks from Gupta, K et al., BMJ, Open, December 2018. And in that relatively unselected, relatively low-risk group, there was an incidence of just 0.5% now I haven't read this paper, I need to go back and look at it, of opioid respiratory depression. That seems very low to me.
I thought so too.
I thought so too. And I actually acknowledge that observation. I didn't think that was the observation you were going to
I've got another observation in a second, which is the no do Sherlock observation, which is the next bit, but we'll come back to that in a second.
We recently just saw some very interesting data on the predictor of opioid-induced respiratory depression to be highlighted in people with obstructive sleep apnea. And whether or not that is indeed true is something that I think is to say the least, a more controversial topic right now.
Yeah.
And the data that was presented in that meta-analysis suggested that there was an association, whereas we've recently now learned that there are other really good data suggesting that there is no such relationship.
With OSA?
Yes.
Okay.
Yes. That the inclination, it's been my bias and prejudice for sure, that OSA was a predictor to heighten the sensitivity of opioids to a respiratory depressive effect has been now challenged, so that it's not an independent predictor.
The teleological argument would be if you have OSA, you do this every night.
You're already.
That's right.
You're already.
You kind of like, so opioids stop you breathing, and it's kind of like, I do that every night. So the teleological argument would be that you're fine. It's
right.
the ones who don't do that every night that get hit.
Exactly.
They said the risk factors from their observational study was cardiac history, OSA, and a pulmonary history. And the kind of non-surprise moment was the higher the dose of opioids, the more opioid-related sleep apnea you would get. So more work to be done in this area, but maybe avoiding opioids and looking after people well would deal with a lot of it.
Yeah, there's a clear dose response of opioids and likelihood for respiratory depression. That's not surprising and, in fact, confirmed. Whether or not that dose response is heightened in a patient with diagnosed obstructive sleep apnea or not necessarily heightened is an area of, I think, requiring further discussion. The data seem to suggest that it does not heighten it.
One of the other things that he was talking about was glucose control.
It's one of the ongoing challenges. So the whole HbA1c screening idea, i.e. identify, poorly controlled diabetics, pre-diabetics, which is a very interesting group, non-diabetics preoperatively, and then do something to improve their chances. And then there's the sugar control once you're in the process of having surgery. And I took away from the various different trials presented that the idea that knowing the HbA1c beforehand is really worth the effort, it was a bit disappointing, I thought, the data from that perspective. Did I take that away correctly?
No, I was just going to say that's what I took.
I agree. Confusing, somewhat confounding to my simplistic sort of way to want to understand the world and the data. The fact that there was a strong association between glucose,
glycemic variability,
well, absolute as well as variability, to poor outcomes, sort of supports my understanding of that data. Yeah. But to then also understand that hemoglobin A1c, which is a marker of long, chronic, if you will, glucose control, did not, is mystifying to me. And I need to dig deeper.
And what was it, in fact, actually, a low hemoglobin A1c?
And that was just bizarre. that was just a,
Can you rationalize that in some way? Yeah.
I can't. And so I have to think deeply about that because it teleologically doesn't make intuitive sense to me.
Well, if there are certain, if you take the Sherpas, for example, that in our Sherpa studies about surviving in extreme stress environments, they have what we would think to be relatively poor glycemic control. So one of their protective possible mechanisms is their reliability on carbohydrate metabolism under stress. And there's also some critical care literature that having higher glucose levels is actually protective as opposed to a risk factor. So a lot of that's come out of Australia, that slightly elevated HbA1cs and being slightly, not crazy sugary, but slightly more sugary in an extreme stress state is a survival advantage. So is there any? It's worth going after, isn't it? It's worth exploring.
I mean,
isn't
from
it?
a biologic, physiologic point of view, that's very interesting. I'm trying to make sense of what is, in my mind, almost a conflated reality of the hemoglobin A1C and the acute phase reacted glucose measurement.
So we need to wrap in a second. So the glucose stuff we'll come back to in greater detail, I think, because there's also a large cohort study from Duke, millions of patients since 1999 with different messages for cardiac and non-cardiac patients, which we'll come back to later on. But a guest's going to sit down within a second. And the last thing from the session I took away was the frailty scoring. So it's very, very practical evaluation of a clinical frailty scale compared to a modified Freed index. You need to look that one up. 645 patients, 73 years old on average, half female. Primary outcome was death or new disability, and the frailty scales were both associated with increased length of stay, increased likelihood of being discharged to an institution as opposed to home, and increased costs. The takeaway was not only frailty scoring still being reinforced as important, but the clinical frailty scale, which you can look up, which is an 8-point score, was easier to do and was quicker to do and was non-inferior.
Right.
So that's a useful takeaway. The CFS at the moment, clinical frailty scale, looks like the go-to place.
Yeah.
Just what I took from that.
I like that. Yeah, I did too. I think that was good.
We need to wrap, I think, Desiree, because we've got guests coming in.
Yeah, we do. We have a couple people coming up here, and we are looking forward to some more discussion about diabetes.
Brilliant.
TopMedTalk. Nick Majerison here. Thanks for listening to TopMedTalk. Now all you need to do is find us on social media. We can be friends on Facebook. We can follow each other on Twitter. We can hang out on Instagram, or we can even gorp at each other on YouTube. Get onto your social media platform, whichever your favourite is, and you're likely to find TopMedTalk there. Whilst you're at it, make sure you've subscribed to this podcast so you never ever miss an episode. Helps us enormously if you do that, by the way. And check out the website, topmedtalk.com. On there you can find the email updates where we update you as to what we're doing each week. And whilst you're online, whilst you're doing your thing on the internet, I highly recommend you download all of the podcasts that we've put out here on TopMedTalk. We do an enormous amount of material here. A lot of it is incredibly valuable and, of course, will be in the future. So I just recommend you download the entire back catalogue if you could. Helps us out if you do that as well. And check out edpom.org/meetings, because if you go on there, you can find out where we're recording and what we're doing, because we go to the big meetings, the EdPom meetings. You may have noticed most of our material comes from some of these wonderful conferences that are organised by evidence-based perioperative medicine. So EdPom, ebpom.org/meetings. Get yourself on there. And why not check out the Dallas Masters course, a perioperative care practicum. Hopefully I'll see you there.